genetic testing. And in fact, there are some centers, including the Mayo Clinic, where they have an opt-out system that necessarily means that every individual who comes with heart failure would get a genetic testing, and of course, the clinician can opt out of the genetic testing if it need be. Now, when we talk about cardiovascular disease, one of the diseases that are very, very frequent and prevalent across the population, but nevertheless underdiagnosed, is this condition called familial hypercholesterolemia. I'm sure every individual in this room would have seen a patient with familial hypercholesterolemia with high LDL levels. This is a genetic disease, and in fact, one of the most prevalent genetic diseases which are undiagnosed or underdiagnosed just because of the fact that they occur in adulthood. Individuals with familial hypercholesterolemia has almost a decade of life lost to lack of diagnosis and lack of treatment. Now, for this, of course, there's a very effective treatment available, and of course, you all do that. It is statins. But even for statins, there is a sort of precision medicine now in place. There is a dosage modification that needs to be required because of the fact that statins can cause myopathy or statin-induced myopathy. And in fact, what we show is that in a recent paper from our own lab is that approximately 10% of individuals in the population would require a dosage modification for most statins, and a third of individuals would require a dosage modification for at least one statin. Now, having said this, I will try to conclude my talk to say what is really happening today and how is it really changing the paradigm in the years to come. And one of the things that is really happening today is genetic diagnosis is actually the end of the spectrum of a workup of an individual. So for example, an individual comes to the clinic, no normal individual comes to the clinic, as you would rightly know, and the clinician needs to make a diagnosis, and of course there is a fallout there. And the right diagnosis is confirmed using a genetic approach. In other words, a very small fraction of people are essentially benefiting from the evidence that we have at hand. Now, of course, with the cost of genomic sequencing reducing very rapidly, what we have an opportunity is to take a step back and reverse this entire thing by having an individual take the test in the first place, apparently normal individuals like you and me, and based on the evidence and actionability, you can act upon it, or the clinician can act upon it, depending upon what you have in your genome. And with decreasing cost of genome sequencing and with population scale programs, of course, you would have heard about the UK 100K programs, the All of Us program in the US, and of course, even smaller countries like Qatar and many countries in the Middle East are doing population scale genomes. That means that individuals would have their genomes available even before they step into the clinic or even before they are deceased. The second is, of course, is a convergence of genetic testing. And today we have a variety of genetic testing being offered in clinics, right from karyotyping to FISH to chromosomal microarrays to panel sequencing or Sanger sequencing. And today they look at very different kinds of genetic variations. But what we need to remember is that all these genetic variations are in your genome, and a whole genome sequencing today can offer a very comprehensive look at all of these variations much faster than any one of these tests. And with the cost dwindling very rapidly, I think this would become the mainstay, not just for genetic diagnosis, but also for screening approaches across the population. Now, when we talk about screening approaches, the obvious question is, what is the yield if you were to apply it in a general population? In fact, we have these numbers from the pilot population scale genome programs from India, and there's approximately 5%, or 1 in 20 individuals in this room, if you sequence, you're all apparently normal individuals, would have a clinically actionable genetic variant based on today's guidelines and today's evidence. And roughly speaking, 2% of them would be for cardiovascular disease, 2% of them would be for hereditary cancer syndromes, and most of them are actionable today with a very standardized methodology for early detection, early action, and of course, targeted therapies. And of course, you would come to, when you talk about population scale screening, there would always be questions about what if we find a mutation which may not be in an individual who has a clinical feature, like for example, the titin mutations, which are very prevalent in the population. Approximately 1% of individuals do have titin truncating mutations. And very recent study from a large cohort in the US, what they've suggested is that they've essentially gone back and screened using echocardiography all people who have a titin truncating mutations. And what they show is that a significant large number of them do have subclinical heart failure. And therefore, putting these individuals on a high risk and a very regular follow-up becomes very important going forward. Now, what you need to keep in mind is that a genome is constant from the day you're born to the day you are dead. But of course, as a clinician, you can ask very different questions at different points in time. In a newborn stage, you would want to look at newborn treatable intellectual disabilities, hemoglobinopathies, very prevalent treatable genetic conditions like Wilson's disease or cystic fibrosis. But very late on, you can look at for a variety of other applications, including late onset diseases like MODY or cardiac channelopathies, or even, for that matter, hereditary cancer predisposition syndromes. I think that would necessarily mean that in the future, probably every child is going to be sequenced at birth, and we are not probably doing it yet. Many other countries are doing it to look at very prevalent, penetrant, treatable genetic disorders going forward. And of course, this year has seen one of the largest RCTs of this kind, which sort of put early newborn screening genome sequencing detection rates at around 3.7% in terms of clinical actionability, and that would mean that we have a completely new tool in our hands to help our next generation. I think to close, let me say that genome sequencing is being affordable, and that is going to be the mainstay in precision medicine. At an individual level, it can afford disease diagnosis, and at a population level of apparently normal individuals, it can provide very useful data for public health decision making. Genetic diseases are not rare, they're extremely prevalent, and therefore, genomes are not for just patients. It is probably for even apparently normal individuals like you and me. And since your genome is constant from the day you're born to the day you're dead, genomic evidence is therefore for a lifetime. Thank you very much.
Thank you for your excellent talk. You talked about pharmacodynamics, pharmacokinetics, and the drug modifications in. Being a nephrologist, I just want to add one small point before I hand over to Dr. Matthew Thomas. And for example, a 60 kilogram person with a normal creatinine of 1 milligram will have a GFR of only about 70 ml per minute. And it is necessary to modify the dose of many drugs. For example, one of the common drugs that is used now for any viral infection is oseltamivir or fluvir. And people are given 150 milligrams BD. To tell you the truth, a person with a kidney failure requires oseltamivir 1 tablet, 30 milligram, and that is to be given on every 3 days. That maintains the therapeutic level. So the dose modification of not only this antiviral drug, but many other drugs above the age of 70 years is very, very important, and I just want to highlight that point before I hand over to Dr. Matthew Thomas for the continuation.
The second topic is tumor agnostic approaches in oncology. Another coming up field, Dr. Prakash NP will deliver the lecture.
Respected teachers, Matthew Thomas sir, Kaj sir, respected elders in the fraternity, colleagues and friends, good morning. The principle of the principle of cancer treatment is to selective destruction of the cancer cells and sparing the normal cells. So we treat different malignancies. The local treatment we will do with surgery and radiation. Systemic treatment traditionally with cytotoxic chemotherapy. Again, the concept is that chemotherapy drugs will destroy the rapidly dividing cells, sparing the slowly dividing cells. That is the concept. And the tumor cells are multiplying very rapidly, and the normal cells are not multiplying at that pace. So the concept is that it will destroy the cancer cells selectively and spare the normal cells. But in reality, it is not like that. It is not sparing all the cells. Some of the normal cells are multiplying, like hematopoietic cells are multiplying very fast. So cytotoxic chemotherapy is not specific, and it has significant toxicity and has a narrow therapeutic window. So how we can optimize the treatment for different malignancies? This is what is being evaluated since long. In 15 years back, the theme of ASCO meeting was personalized medicine, personalized cancer care, or precision cancer care. So how we can offer precision cancer care? So we know that a patient with the similar histology, like say patient having a lung cancer, in one person behaves differently from the other person. So why it's happening? Some of them will respond to the chemotherapy, some of them will not respond. Some of them will have toxicity, some of them will not have any toxicity. Why it is happening? It is happening because of we know that it's happening because of the heterogeneity in the biology of the tumor and heterogeneity in the biology of the patient. So how we can personalize the treatment? So we can personalize the treatment by identifying the tumor and the patient characteristics. What the tumor characteristics, we can identify biomarkers. How can we identify biomarkers? We have to do the genetic studies as the previous speaker mentioned. So the DNA has to be sequenced. Whether the transcription is happening or not, that we have to identify by microarray. Then proteomics, metabolomics, and the immune profile of the tumor has to be characterized. So based on the identifying the tumor biomarkers, even now many targeted therapies are available, and the first one and which has revolutionized the treatment of chronic myeloid leukemia is BCR-ABL tyrosine kinase inhibitor. 25 years back, when I started learning oncology, patients with chronic myeloid leukemia, the median survival was only 3 years. But now, today, the life expectancy of chronic myeloid leukemia patient is at par with the normal individual.